Basic principle of pharmacy, topic 45, video part 2. Aseptic technique. Definition: aseptic technique is a set of specific practice and procedures performed under carefully controlled conditions with the goal of minimizing all items in a sterile field must be sterile. Sterile package or fields are spent or created as close as possible to time of actual use. Moisture areas are not considered sterile. Contaminated items must be removed immediately from the sterile field. Only area that can be seen by the clinician are considered sterile. That means the back of the clinician is not sterile. Gowns yani lab coat are considered sterile only in the front, from the chest to waist and from the hands to slightly above the elbow. Tables are considered sterile only or above the level of the table. Non-sterile items should not cross above the sterile fields. There should be no talking, laughing, coughing, or sneezing across sterile fields. There should be no talking, laughing in. Personnel with colds should avoid working while ill or apply a double mask. Edges of sterile areas or fields, generally the outer inch, are not considered sterile. The edge of sterile area or fields are not considered sterile. لبه ها sterile نیستن. When in doubt about sterility, discard the potentially contaminated item and begin again. A safe space or margin of safety is maintained between sterile and non-sterile objects and area. A safe space or margin of safety is maintained between the sterile and non-sterile object and area. When pouring fluids, only the lip and the inner cap of the pouring container is considered sterile. Only the lip and inner cap of the pouring container is considered sterile. The pouring container should not touch the receiving container, and the splashing should be avoided. پخش کردن مایع should be avoided. Tears in barriers are considered breaks in sterility. Tears in barriers are considered breaks in sterility. Biological therapy. Biological therapy, sometimes called immunotherapy or biotherapy or biological response modifier therapy, is a relatively new addition to the family of cancer treatments. Biological therapy include interferon, interleukin, colony-stimulating factor, monoclonal antibody, vaccine, gene therapy, and non-specific immunomodulating agent. Biological therapy include interferon, interleukin, colony-stimulating factor, monoclonal antibody, vaccine, gene therapy, and non-specific immunomodulating agent. Interferon, interleukin, CSF, monoclonal antibody, vaccine ها، gene therapy, and non-specific immunomodulating agent همه biological therapy هستن. نه تنها monoclonal antibody. می‌بینی؟ تو چی کار میکنی الان؟
گرمه دست من گرمه.
خب بچه پاشو بذار راحت باشه. خب
میره پایین دست من راحت میشه.
تیبیه؟
اون زیر.
تیبیو؟
اون زیر.
تیبیو؟ آیا قربونه پیسماری گلم برم. بیا اون بالا. برو برگشت تو خونش. بیا خونه درست کرده اینجا برای خودش. برای خودش خونه درست کرده. خب بگی بخ راحت بشی. Biological therapy by rituximab. How the rituximab work? This is a rituximab or Maptera. This is a so expensive drug here. This is a lymphocyte, natural killer cell, component mediated of the cytokine. Rituximab binds to the CD20 on the B lymphocyte and change the lipid raft. See? And electron effectors of apoptosis. It affects on the apoptosis because this is a SRC kinase, SRC kinase, and then component of modified cytokine change, and finally the natural killer cell comes here, bonds FC receptor of natural killer cell bonds to the rituximab and kill the cell. Okay? Rituximab bonds to CD20 on the B lymphocyte and start the apoptosis by the help of natural killer cell. Trials evaluating rituximab plus chemotherapy as a first-line therapy in patients with follicular lymphoma. حالا چه تریال های انجام شده according با rituximab plus chemotherapy as a first-line therapy in patients with follicular lymphoma. In younger patients and patients with a high IPI score, key findings from a number of phase 2 trials have led me to use more aggressive first-line therapy with rituximab plus chemotherapy. All of those trials consistently demonstrated a higher clinical complete response rate and a much higher molecular complete response rate than reported with chemotherapy alone. The molecular complete response rates in many of those phase 2 trials were approximately 40 to 50 patients. With any combination chemotherapy regimen, the molecular complete response rate in patients with low-grade lymphoma is less than 20%. The molecular complete response rate is thought to be a surrogate marker for a better quality response. Recent data from 2 large randomized phase 3 trials comparing CVP or CHOP alone or with rituximab demonstrate that the addition of rituximab to chemotherapy more than doubled the median progression-free survival. Neither of those 2 trials has sufficient follow-up to draw any final conclusion about overall survival. But it is difficult to ignore a therapy that will probably make a difference. Therefore, I now treat that group of patients with combination of rituximab and chemotherapy instead of chemotherapy or rituximab alone is better. Randomized phase 3 trial comparing R-CHOP to CHOP as a first-line therapy in patients with follicular lymphoma. Eligibility: patient with follicular lymphoma, R-CHOP, the randomized condition with CHOP or without randomized CHOP and with randomized CHOP, and CRPR, autologous stem cell transplantation, and alpha interferon maintenance. What's happened? With overall response rate by CHOP was 90%, by R-CHOP was 96%. The p-value, the probability is 0.01. It means the chance, the chance that the data is not real is so low. It means all of the data are real. Because the probability is low, it means the data are more real. It means the probability of the misdiagnosis and miseffect is low. Complete response rate is 80%, 21%, and there is no probability, 0. Median PFS and months 15%. R is rituximab with CHOP. CHOP is a cyclophosphamide, doxorubicin, vincristine and prednisolone. PFS is progression-free survival. CR is complete response, and PR is partial response. My source is a Hideman. Journal of Clinical Oncology. Rituximab maintenance treatment of replace and resistant follicular non-Hodgkin lymphoma, long-term outcome of the EORTC 29981 phase 3 randomized intergroup study. What's happened? The progression-free survival decrease after many years. It means it helps the patient to be cured. Good. Result: rituximab maintenance significantly improved progression survival compared with observation of 3.7 years versus 1.3 years, and by the probability less than 0.01. Hazard ratio is 0.55. Effect of rituximab maintenance on the treatment on progression survival. Good. On the Hodgkin lymphoma. For Hodgkin lymphoma, we can use rituximab by the help of the other drug. This is the combination chemotherapy. The clinical and economic value of rituximab for the treatment of hematologic malignancy. Different table. Cancer vaccine. Therapeutic vaccine have two objectives: priming antigen-specific T cell and reprogramming memory T cell. That means a transformation from one type of immunity to another, for example, regulatory to cytotoxic. Recent successful phase 3 clinical trial showing benefit to the patient. Revived cancer vaccine. Dendritic cell DC are essential in generation of immune response and as such represent target and vectors for vaccination. Cancer vaccine. anti-DC antibody fused to cancer antigen and DC activators, targeted a specific DC subset in vivo. Ex vivo generated artificial DC, ex vivo cytokine deriving instruction to generate appropriate cytotoxic effectors and helper T cell. Random DC targeting peptides with adjuvant viral vector, DNA vaccine and transduced tumor cell. Combination therapy with optimized DC-based vaccine, blockade of regulatory and suppressive pathway, and breakdown of tumor environment, and personalized therapy. It means the cancer vaccine has a different way. Therapeutic vaccine have two objectives: priming antigen-specific T cell or reprogramming memory T cell. Antigen-specific T cell and reprogramming memory T cell. That means a transformation from one type of immunity to other. For example, regulatory to cytotoxic. Instead of regulatory immunity to cytotoxic immunity. Recent successful phase 3 candidate trial انجام شد روی dendritic cell ها DC are essential in generation of immune response, because the dendritic cell are essential in the generation of immune response and as such represent target and vectors for vaccination. No. Here, anti-dendritic cell antibody, randomized dendritic cell targeting, or maybe ex vivo generating artificial dendritic cell. Not just for papillomavirus that cause the warts. This is it's such an infection that can cause the uterine cancer. This is a special cancer vaccine. We have it, anti-dendritic cell. Again, dendritic cell are essential in generation of immune response and as such represent target and vectors for vaccination. If the dendritic cell gets the immune response and allow the tumor to grow, we should do something against the dendritic cell, anti-dendritic cell antibody. Or we can peptide with adjuvant viral vector or DNA vaccine or transduced tumor cell to randomize dendritic cell targeting. Some visualization practice. Understanding your cancer video. Your cancer, this is a video targeting angiogenesis and tumor cell proliferation, or we can do by Herceptin, a multimedia approach targeting HER2 positive breast cancer, and gefitinib, mechanism of action. این ویدئو رو میبینیم. تموم شد اینجا دیگه.
Welcome to Invita Medical Centers of America. We're committed to educating you so that you understand the disease that you're fighting. Our goal is also to ensure that you are involved and...
Skype camera.